Welcome back to Tech Tuesday on All Sides. I'm your host, Ann Fisher. Patient history is a critical part of medicine. What a physician learns during that process could reveal a key fact in a diagnosis. But training physicians to perform this process takes time and coordination. The Ohio State College of Medicine is turning to virtual reality for help. Douglas Danforth researches and studies virtual patients and VR in his lab at the OSU College of Medicine, where he's an associate professor in the Department of Obstetrics and Gynecology. Welcome.
Hi, Ann.
What is the traditional training for patient history taking?
So typically we train our students almost in the very first week. We teach them the questions they should ask, the order they should ask them, what questions are important in which cases, and then they practice maybe with each other or they practice with what we call standardized patients. Standardized patients are actors from the community that we hire to come in and portray a patient with a particular illness or condition. And so the students will interview a standardized patient, take a history, and people like me will be watching that encounter, and we use that encounter to grade the students, how well they do in terms of taking a history and learning to interview patients.
Is that part of the grading process when they use actors, or is that part of the training process, or both?
Both.
Okay.
So we use actors for them to practice. They practice with each other, but especially early on, medical students are not great at giving advice. They don't know which questions to ask yet. And so we use standardized patients to help them practice. But one of our primary uses is to assess the students to make sure they have the right skills.
And this is something that goes on throughout medical school?
That's correct. We use it a lot in the first 2 years. I'm the director of the first 2 years of medical school, so we use it a lot then. We use it in the third year as well. And then some of the standardized national exams that students have to take to become certified to become a doctor will use the same thing. They'll use a trained standardized patient to assess the students.
So where does that fall short? Why did you look to virtual reality to replace it?
Well, the supply of standardized patients is limited. It's difficult to schedule that, okay. And they're it's expensive to run a standardized patient program. You have to have staff, facilities, you have to hire the patients, you have to train them. So there's a lot of infrastructure involved and a lot of expense involved. So we thought if we could make virtual standardized patients, we could give students the opportunity to practice their history-taking skills before they got to a standardized patient or even a real patient.
So how did you approach this task then? What were the challenges?
So the biggest challenge with this is creating the artificial intelligence so that the virtual patient can communicate with the student using natural language. Our students just speak their questions to the virtual patient. A virtual patient is an avatar representation of a human patient. And the students speak their questions, and the virtual patient speaks the answers. And so designing the artificial intelligence and the dialogue management to manage that dialogue and understand the nuances of that interaction is especially difficult. It's if you think about talking to Alexa on Amazon Echo, Alexa can give you directions or turn on the lights, but you can't carry on a conversation with Alexa. So the software that you need for this kind of dialogue is a little bit different, and it's more difficult to do, to keep track of the conversation. What are you talking about when you say something like, when did that happen? So we have to use some pretty sophisticated software to make sure that the patient can answer the questions that the students ask. What
kind of software has been developed? I mean, why is it? Are there other uses for this kind of software that already had been already been working on it for?
One of the main uses is in what they call chatbot technology. Okay. So there's a lot of websites and companies that want to develop chatbots to help you order a widget or get some customer service. So in areas where the conversation is pretty narrow, you're talking about a specific thing, the software for that is actually pretty good.
Medicine, though, and how you're responding to a physician's questions about your condition is so nuanced in a way, isn't it?
Yes, it is very nuanced, but the way the software that we develop for the virtual patients just has to understand what the student doctor says, because we're teaching the students how to ask the questions. So the number of questions in a doctor-patient interview is finite. We don't worry about trying to answer how did the Buckeyes do, or is it going to rain today? What is difficult and what is almost infinite is the ways you can ask those questions. So there are a simple question: what brings you in today? That's pretty straightforward, but there are 100 ways to ask that question. And so the software that we use manages all of the different possible variations of that so that the virtual patient understands you're asking what brings you in today, and they provide the answer.
So it's an interesting balance between letting the physician or the physician in training go in there and naturally ask questions in the way that fits their delivery, their personality, that kind of a thing.
Exactly. And the technology is matured in the last 5 or 10 years to make this all work pretty well. The speech understanding, so the conversion of the speech to text in the last few years is now very, very good. And the machine learning, where how we train the software to understand what the meaning of the question is, that has gotten very good in the past few years.
Earlier this month, you tested virtual patients that spoke limited English, and it's obvious that's an important issue. But how does that work? That seems like you're throwing a wrench into the operation.
A little bit, yes. But so the Department of Medicaid wants to make sure that their providers are aware of some of the cultural considerations that their patient population will have. And so we wanted to help train them how to interact or interview a patient who doesn't speak English as their first language. There are different considerations for that. You have to phrase your questions a little bit differently, and you have to determine whether or not your patient is really understanding you. So we created a simulation and a system where we would train the Medicaid providers a little bit about that. So when do you use an interpreter? When can you use a translator? When can you use a family member, not use a family member? And so then we teach them a little bit about it, and then they get to practice with a virtual patient who has limited English proficiency.
And part of then that exercise is understanding and learning when you need to get a translator.
That's correct.
Okay.
And learning some skills.
This isn't to replace translators.
Yes,
necessarily.
Learning some skills to determine whether or not your patient is really understanding you. Because a lot of times a patient who doesn't speak English very well will nod their head and make you think that they are understanding everything you're saying, but really they don't. And so we also teach them some techniques. For teach back, for example, you explain something to the patient and have them explain it back to you so that you can determine did they really understand the medication that I want them to take or when their next appointment is.
You know, my experience with elderly parents suggests to me that that's another issue is cognitive, changes and detecting those. And also, and I know there's a rote questions to ask on that case, but also hearing loss.
Yes, all of those I think.
And they like to nod and just say, yeah, I get what you're saying.
They're important. And no one wants to, appear foolish. And so oftentimes, even when patients who have normal English proficiency, but they don't understand the medical terms that you're using, or they're confused because they're nervous, they'll nod and maybe hope that a family member who's there will explain it to them later. And that often can lead to, misinterpretation of medicines or things like that.
You're listening to Tech Tuesday on All Sides with Ann Fisher. It might sound like it's Wellness Wednesday, but you know that point in a conversation with a physician where they're trying to figure out why you're there. We're talking about how OSU this College of Medicine, is using virtual reality to help train physicians in that process. If you have a question or comment, you can give us a call, 614-292-8513, or email us at allsides@wosu.org. My guest is Douglas Danforth. He researches and studies virtual patients in VR in his lab at the OSU College of Medicine. Now, this is something that another benefit of this VR and having having software that does this is that students can take it with them. It doesn't have to be in a VR format for them to use it. They can just take it on the iPad or whatever they have.
That's correct. In fact, most of the time we deliver the virtual patients on an iPad. So the students just open up their iPad. They open up the virtual patient and they speak the questions. And
do they wear a headset?
They generally don't. They can if they want. It does result in some interesting conversations when they're trying to interview the patient at Starbucks or in front of the TV. The virtual patient hears all of the audio
chatter,
that's coming in, and sometimes they get confused when the student is ordering a latte and they're trying to understand what they're actually saying.
The students get immediate feedback from the program too. How does that differ from what you provide when you're giving feedback?
So with the standardized patients, they will give feedback in the practice sessions. But when we're doing assessments, there are so many stations we don't have time to stop every assessment and give students feedback. With the virtual patients, the software records all of their questions, categorizes them, and when they're done, they get a report. Okay, I asked these questions in these categories, but I missed these questions here. And so they get to practice. And then they also get an expert's approach to the case. So they can compare their performance against a gold standard and understand in different cases why it's important to ask a particular question for a patient that, for example, comes in with back pain. Why is it important to ask if the pain radiates down your leg or if it just stays in your back? The expert's approach to that explains the importance of those questions, and they can compare their performance against an expert.
How long did it take to develop this software?
We've been working on it for almost 10 years. We collaborate. I have colleagues in the Department of Computer Science and Engineering and Linguistics. They do a lot of the sophisticated natural language understanding software, and then there's a separate bit of software that we use that relies on patterns and rules, and I write that software. And actually, our system uses both. When a question comes in, both systems analyze it, and if they agree, we have high confidence that we understood the question and we provide the answer. If they disagree, then we have a third bit of software that chooses between the two based on which one is more likely to be correct. So even with all of that, and that's a pretty complicated system going on in the background, we still only get the answer right about 8 out of 10 times. Under ideal circumstances, we're above 90%. But if a student's in a noisy environment or talking to their roommate or asking questions in unusual ways, we're about at 80%.
How many versions of virtual patients do you have?
We have about 10, about a dozen or so what I would call typical virtual patients, just patients with different chief complaints: back pain, chest pain, abdominal pain. We have some specialized patients we're creating now. We're creating a virtual cancer patient to help doctors and nurses practice difficult conversations with patients who've just received a difficult cancer diagnosis. And we're also creating a patient with opioid use disorder. So physicians and healthcare providers can practice interviewing or interacting with a patient who abuses opioids and might be a candidate for medication-assisted treatment.
What about people who are just not communicative? They're difficult to talk to. They're not good at describing what's wrong.
I think any system that allows students to practice and get comfortable with that. So one of the advantages we see of the system is not ever to replace interacting with a real patient. That's the ideal. But if students can practice, get the questions in their mind, get all of the things that they need to ask, so they're not thinking about that when they're talking to a patient. That comes naturally. Then they can focus more actually on the patient and eliciting information from the patient, responding with empathy to the patient's care and concerns.
The same grant, that Medicaid grant that you referred to, it also funded this training, will fund training for building empathy with dementia patients.
That's correct.
And how does that process compare and contrast with VR that covers English as a second language, for instance?
It's a little different. So we haven't used a lot of actual virtual reality yet. We can you can put the headset on and actually be in the room with a patient. But as I said, most of ours are done via the iPad. But the Dementia Project is done by the Advanced Computing Center for Art and Design, and they actually have you put the virtual reality headset on, and you are experiencing what life would be like if the world was confusing to you. And so you actually get to experience what a dementia patient might experience. Things that, this cup of water here is clear to me, but a dementia patient might be confused about that. So the software allows you to experience what a dementia patient is actually experiencing, so you have a better sense of what the patient is going through, so you can help them a little bit better.
And what are the next steps? What's next in this universe?
So one of the applications that we're using the dialogue technology, the virtual patient technology, is in a virtual reality simulation for mass casualty training. So we just got funded to create a virtual reality simulation of a mass casualty incident. We are creating initially a subway bombing scene, and we'll do an active shooter after that. But the first responders, paramedics, EMTs, medical students, will put the virtual reality headset on, and they will actually virtually be in the bombed out subway platform. There will be victims all around, and they will have to, what we call, triage that scene. Identify who needs care most urgently, who can wait. They will go around to the victims. They will identify what life-saving procedures are needed and perform those. And as they're doing that, the system will grade them. How quickly are they doing it? Are they categorizing the injuries correctly? And the virtual patient technology will allow them to communicate with their victims. Can you hear me? Are you hurt? Can you move? We'll be using the technology to train first responders.
What's the cost-benefit analysis of this technology going forward?
The advances in the virtual reality technology now make it really inexpensive once you get a simulation trained to be able to deliver that to a lot of folks. So in the past, if you wanted to do a simulation like that, you would have to go to a clinical skills center that had a very expensive virtual reality system built in. When we get our system built, we will simply take it to Worthington Fire Department, and all it requires is a virtual reality headset and a little bit of space, and all of the paramedics, the fire department folks, can go through and actually practice in their space. So it makes it a lot more accessible to a wider audience.
What kind of feedback do you get from the students, the medical students, about this and how they like it? Or that's got to be part of the equation. It is.
We get feedback from all of our students. In general, the students like the ability to practice. They especially like getting feedback on how they did. They get frustrated when the patient doesn't understand what they say, because, we're guessing always, and we guess right about 80%. But I think the biggest frustration that they have is they ask a question that seems like a reasonable question, and for whatever reason, our software doesn't pick it up right, and they get frustrated because it's not answered.
Well, Douglas Danforth, thanks for joining us today to talk about it. I appreciate your time.
Thanks for asking me. Bye.
Douglas Danforth, he researches and studies virtual patients and VR in his lab at the OSU College of Medicine. We have more Tech Tuesday coming up, so stay with us. This is All Sides with Ann Fisher on 89.7 NPR News.